Welcome back everybody to the second video in the ICU Insights series. So today we'll be talking about AKI. Now AKI is something which is very universal irrespective of the branch of medicine you are practicing, whether you are in anesthesia, ENT, optha, obstetrics, medicine, surgery. You are going to encounter AKI a couple of times every week. So we must be very clear in what exactly is AKI, how do we diagnose AKI, and what are the steps that we need to take as soon as we encounter AKI. So what exactly is AKI? If I have to explain it to a layman, I will just basically say it is a decline in renal function over hours to days. But we must diagnose it using the KDIGO guidelines. So according to KDIGO guidelines, AKI is an increase in serum creatinine levels by more than equal to 0.3 mg per deciliter in less than 48 hours, or it is an increase in serum creatinine level by more than 50% from the baseline in less than 7 days. Now the term from the baseline is very important. So we have many patients who have diabetic kidney disease or hypertensive kidney disease. In these patients, the baseline of creatinine is very high. So patient even normally will have a creatinine of 2. So in these patients, increase should be more than 50% from the baseline. So in these patients, we will take the baseline as 2. Okay, so there are various stages of AKI. So the first stage, according to KDIGO, the serum creatinine should be 1.5 to 1.9 times the baseline. The urine output should be less than 0.5 ml per kg per hour for 6 to 12 hours. And AKI 2, the baseline creatinine you have to note, and from that you have to see whether the serum creatinine is rising 2 to 2.9 times, and the urine output should be less than 0.5 ml per kg per hour for more than 12 hours. In AKI 3 is the most interesting because there are multiple criteria to diagnose AKI 3. The first is serum creatinine should be 3 times the baseline, or the serum creatinine value is more than 4 mg per deciliter, or there is a need for renal replacement therapy, or in simpler terms, there is a need for hemodialysis or peritoneal dialysis, or in children less than 18 years of age, the eGFR is less than 35 ml, or the patient is anuric for 12 hours, or the urine output is less than 0.3 ml per kg per hour for 24 hours. So what exactly must we do as soon as we encounter a patient of AKI? The first step is always going to be to do a USG whole abdomen or a ultrasound whole abdomen. So we basically do it for 2 reasons. One is to rule out chronic kidney diseases, and the second is to rule out obstructive causes. So in many hospital settings, the first instinct of any doctor to see anytime they see AKI is to load the patient with fluids. Now this is a very wrong criteria, because if the patient already has CKD, or if the patient has obstructive causes like renal calculi, in these you are actually worsening the patient. So you have to do a USG whole abdomen or an ultrasound whole abdomen of the patient to rule out chronic kidney diseases or obstructive causes. Once you have done that and the USG is normal, then you can do urine analysis to rule out whether it is a pre-renal cause of AKI or it is a renal cause of AKI. In renal causes, there are mainly acute tubular necrosis, ATN, or acute interstitial nephritis. So I hope this video gives you a lot of clarity on what exactly is AKI, how do you diagnose it, and what can you do as soon as you encounter AKI. So I hope you like this new series, ICU Insights, and if you have any comments regarding how I can improve as a YouTuber or what kind of content you guys want me to make, you can comment down below. I read all the comments. Also, you can if you want, you can subscribe the channel and you can share it with your friends. Thank you.